Good morning, everyone. Hello, how are you? Thank you all so very much for being here, and thank you for being so patient. All of our panelists are here now. We really appreciate you all taking the time to come this morning. Welcome to GOV Talks. This is a program that was created by the Governor's Office of Program and Planning. And each month, what we do is we delve into a topic, a problem, an issue that's impacting Louisianans from north to south and everywhere in between. My name is Shauna Sanford, and I have the pleasure of moderating the panel today, and we're going to be talking about the misuse and the abuse of opioids. It is a problem that has reached epidemic proportions here in Louisiana and all across the country. And while our panelists are here to provide a lot of information, we also have some experts in the audience. I'm going to be calling on them as well to share their expertise, but I know that you all came with questions, that you have a lot of questions, not only for our panelists, but I know whatever question you have, others have it. Those of you who are here in the room with us, and also those of you who are watching on the web. So at any point in time, please do not be shy. Come up to the mic and ask your question, and we're going to be happy to answer it. This is an important conversation, one that we all need to have, because as officials say, the overprescription crisis is leading to addiction, it's leading to more drug-related deaths, and even higher insurance costs here in Louisiana. And I came across this fact. I wanted to share it with you. Many of you may know this, some of you may not, but Louisiana is one of 8 southern states that has more opioid prescriptions than it has residents. And in 2015, we had the 6th highest rate at which painkillers were prescribed per capita. So that is a problem. Our guests today know this issue very, very well, and I want to introduce them to you as well. We have Special Agent Brett Byerly, who is with the Drug Enforcement Administration. Next to him is Carice Schulman with the Louisiana Perinatal Commission. And next to her, Dr. Joseph Cantor, an emergency room physician and medical director for the New Orleans Department of Health. And behind me, we have a gentleman who is with us all the time whenever we do have functions here in the press room, because we want to make this available to as many people as possible, those who can hear and those who are hearing impaired. So we thank you very much, Daniel Birch, for being here with us today. Our focus today is threefold: the problem, the treatment, and the prevention. So let's just begin at the beginning. Define for us, when we're talking about opioids, what exactly are we talking about? Dr. Cantor.
So we're talking about medicines that are all related, chemicals all related. So that includes heroin, that includes prescription medicines, painkillers, typically Percocet, Norco. All these medicines do essentially the same thing, and they depress someone's respiration, they depress someone's central nervous system. The effect of taking too much of these is an overdose. Your body stops breathing, and if you're not resuscitated, you could die.
And you are an emergency room physician. This is something that you deal with quite a lot.
We see this every day. Every day people come in with overdoses as a result of their addiction.
Carice, please tell us, this is not just affecting adults, but children as well, newborns.
Yeah, so...
and if you could pull your mic a little bit closer so we can hear every single word that you have to say.
in between words, right? So the Louisiana Perinatal Commission is very interested in neonatal abstinence syndrome. And what this is a constellation of symptoms that newborns experience if they have been exposed to opioids prenatally and then have withdrawal symptoms after, when they're born. And so this also has skyrocketed over the last 10 years. The incidence as well as the costs associated with this is just out of the world.
Well, when you and I talked and you mentioned this syndrome, I had not heard of this syndrome, and maybe many of you have, maybe some of you have not, but it's neonatal abstinence syndrome, and that specifically refers to babies who are born to mothers who are addicted to opioids. Is that right?
Yes.
Yeah. And what are the symptoms? What are these babies experiencing?
Well, I mean, withdrawal of the opioid is very severe in many cases. There's also a higher risk of congenital abnormalities and low birth weight and developmental neural tube defects and things like that. But the withdrawal is just a very heart-wrenching thing to see and observe. They have difficulty feeding and connecting with their parent, and so it's and they have to have a long hospital stay to kind of wean them off of this, or not wean them off, but sometimes it is a weaning process that has to happen.
And right now, do we know much about the long-term effects? And Doctor, you can
and
jump
please,
in.
I'm not a clinician, so please jump in. But in terms of long-term effects, there is more research going on to help determine what those might be. There is a strong suspicion that there are some developmental issues that will show up later on in life. So there is a lot of research right now on this.
Dr. Cantor?
Let's just say, so neonatal abstinence syndrome is what happens when a child is born to a mother who is using opiates throughout her pregnancy, whether illicit like heroin or prescription painkillers. The prevalence is about 6 kids in every 1,000 births that happen in a hospital. These are national numbers, and that's actually quite a big number. The most important thing to know about this is that it's a treatable condition. If the doctors, if the obstetricians know that a child is exposed throughout the term of the pregnancy, it can be treated quite easily, and kids do very well, but they have to know that. So the messaging is that pregnant women need to be complete partners with their caregivers throughout the pregnancy when opiates are involved. Involve them early, be honest, be upfront, involve family members. When everyone's on the same team about this, the results can be quite good. Kids can live quite normal lives if everyone knows up front and can prepare for it.
So Special Agent Byerly, where do you come in on this? Talk a little bit about what's happening here in Louisiana, and also give us the national picture.
Yeah, let me start off by telling you about the national picture. And in doing so, just to give you a little bit of background, I've been working narcotics investigations for just over 18 years, and I've never seen anything like what we're experiencing now with the opioid epidemic. And DEA, the way we look at it, it's not just the prescription drugs, it's the heroin, it's the synthetic heroin, it's the fentanyl, it's other synthetics that we're seeing coming in from Mexico and from China. And in the 90s, when I began doing this work, it was the methamphetamine. It was the methamphetamine and the safety involved. This trumps that tenfold with the overdoses, the amount of people. 120 people are overdosing a day, and more than half of them are overdosing from the opioids. When I get on the phone with other DEA agents in other cities and even overseas, that's all we're talking about now is heroin and opioids. I mean, we're still investigating the other drugs, but I mean, right now there's such an epidemic, and there's such a safety issue too. I don't know if you've heard of, and I think it's on the opioid fact sheet here, the fentanyl. The fentanyl is so dangerous. If you can just imagine a few grains of salt, if I were to sprinkle it on the table, if that were to come in contact with your skin, it could kill you immediately. So that's kind of from DEA's perspective. I mean, we're seeing it from an investigative side. DEA also has a regulatory side, and we're working very close with the medical community to combat this. And then we're trying to get involved in the communities and work, with the communities to try to get in front of this for community awareness.
We use this term epidemic proportions. We say that a lot, and that's associated with a lot of issues. Does that really resonate with those of you who are here when you come into contact with people and you're trying to educate the public at large? Does it really resonate? What does it mean when we say that it's epidemic proportions?
So let me put it into some numbers. Since 1999, the number of people who have died from overdose deaths related to opiates has quadrupled. That's an epidemic to me. Every single person has someone in their life that is affected by the opiate crisis, whether it's a family member, a close coworker. I promise you do, whether you know it or not. This affects everyone, and it goes down through families, and we need to treat it like a public health issue. We need to treat addiction like the medical disease it is.
Not a crime.
Absolutely.
Okay, well, let's talk a little bit about that, but I want to key in on something that you just said, and I'd love for all of you to chime in on this. What does the face of someone who's addicted to opioids look like?
I can tell you what it looks like, but first, just to kind of jump on top of what you just said and expound on that a little bit, there's no socioeconomic barrier.
Right.
There's no race. There's no particular gender. It can be someone sitting next to you on the train or the bus or standing in line in front of you in Walmart. It doesn't discriminate. In all of these investigations, we're seeing it everywhere. We're seeing it in the inner cities. When I first started doing this, I was working in St. Louis, Missouri, and it was in the inner city, and and you see the phrase here, in an alleyway with a dirty needle. It was black tar heroin. Now it's everywhere. It's in your middle class homes. It's in your lower class, your upper class homes. It's everywhere, and that's what a heroin addict looks like now. And the doctor, when he said whether it's touched you or not, I promise you it has. And it didn't come full circle to me till a friend of mine I'd grown up with several years ago, I get the call that he had overdosed. And I mean, the guy, and never in a million years would I have thought this guy was using heroin. So that's what you're.
Well, it could look like any of us.
Exactly.
It could look like any of us. And it's so interesting that you share that, because this morning a close friend of mine shared a story very similar to that. She had a family friend, whose son recently died from an overdose of heroin. College educated, had gotten to the point where he was spending his entire paycheck on heroin. It touches so many people. But what are the symptoms? You just said it could be someone in your life, someone you know, someone you don't know. So are there symptoms? Are there things that we could recognize?
Thank you for that question. I could not agree more. It affects every single walk of life: sex, race, socioeconomic status. You want to know what the face of an addict looks like? Look in the mirror, look at your family members. It could very easily be that. The difference is that some people have more access to treatment than other words. Medicaid expansion has done a great benefit to us all in Louisiana by giving access to treatment to people that didn't have it before, and I'm thankful for that.
Yes.
What are the signs? How do you know? You might not know if someone is addicted to opiates. If someone has an addiction to prescription pain pills, you might not know until it's too late, until they have an overdose or it shows in some other way. The signs of an overdose are quite obvious. People get very somnolent, they have trouble breathing, they pass out. That's obvious, but what we would like to do is educate people about addiction so that they can seek treatment before that happens.
Yeah, and we have to give thanks to our governor, John Bell Edwards, for adopting Medicaid expansion and the fact that it has helped well over 380,000 people who now have coverage who did not have it before. I think that's something to applaud. I think that's an awesome thing that has happened.
Absolutely, and it's important to note that coverage includes substance abuse treatment, which is vital.
Yeah, so what do you do? What do you do if you see,
Well,
yes?
I'd like to just echo what you said a little bit earlier, and the fact that we really need to look at this issue as a chronic illness and not as a moral dilemma. I think that the implications for us looking at it that way has great implications for the training that we give to our providers, for the way that we coordinate our care and don't make it all separate and individualistic in terms of mental health over here and substance abuse is over here and health care is over there. So it has strong implications for that. With diabetes, you would never actually, give someone a 30-day supply of insulin and then give them a nice handshake and say, okay, go to the basement and have some meetings in there and you'll be good. And that's what we do with, addictive disorders.
Yeah, but how has that transferred to what you do, Agent Byerly, that way of thinking? Because it is shifting.
Yes, I can tell you firsthand, I couldn't agree with you more, because we know from a law enforcement perspective, we're not going to be able to arrest our way into solving this. There's no way. So we've got to look to the medical community and other groups to help us solve this.
So what do you do? If you notice the symptoms, if you see the signs, what do you do as a parent, as a friend, as a coworker? What do you do?
I think the first thing you do is you show love. This is a disease. People suffer from it just like any other disease. And the first thing that people need when this is an issue in their life is love and compassion. Bring them closer into you and reach out. The next step is to connect with resources. And those can either be through a primary care doctor. If anyone doesn't have a primary care physician, they need one, whether they realize it or not. And also reach out in your area to figure out where the substance abuse resources are. A good place to go would be to what's called the local government entity. So there are 10 local government entities in Louisiana that oversee behavioral health coordination for those regions. So here in Baton Rouge, it's Capital Area Human Service District. New Orleans, it's Metropolitan Human Service District. Lafayette, it's Acadiana. Out in Lake Charles, it's Imperial Cashew. Anyway, there's 10 of them. They're pretty easy to find online. They would be the first step to figure out where treatment resources are available close to you.
Are there enough? Never enough, huh?
Never enough, certainly more than we had before. and always room for improvement.
Well, and I appreciate you giving out that information, because I know those of you who are in here are going to be able to take this back to your organizations, to your communities to share. And really, that's the whole point of this, is getting out good, solid, accurate information that you can take back and share. But it's also answering your questions. So I want to encourage those of you now who came with questions, and I know you did come with questions, to please just come on and make your way up to the mic right now so that our panel can answer those questions for you. And the questions that you have, others have them as well here in this room, also those who are watching online. So do not be shy. Don't keep it to yourself, because that answer could very well help someone here today. So I really, really want to encourage you to go ahead and ask your questions. Clarice, tell us more about the commission, because you all have come out with a list of recommendations. Those recommendations were in response to a study resolution here in the legislature last year. Is that right?
Yeah, 2015
Oh,
was the resolution,
2015,
and then
okay.
we submitted the report in 2016 of March.
Tell us about that.
So the Louisiana Perinatal Commission is charged with making recommendations to the legislature after review of policies and guidelines that impact infant mortality. And so this is one of the charges that was given to the commission. And so through that period of inquiry, we're made up of 16 members, by the way, statewide. And through that period of inquiry, we really had a lot of conversations with a lot of different agencies and hospitals and associations to really get at what was going on with specifically neonatal abstinence syndrome. And we came up with kind of 3 categories of recommendations, one of them being related to prevention, and that includes preventing opioid use by looking at what the prescribers are doing and making sure that there's some guidelines that prescribers of opioids follow. I think that's important.
Well, let's just stop
there,
right
pause.
there. Let's put a plug in that right
Okay,
there,
'cause I have a
because we're
long
talking
list.
about prescribers. We're talking about the doctors. And where are we, Dr. Cantor, with prescribers? And how much of that is the problem?
It's a component, and we're not where we need to be, but we're making some progress. You mentioned this stat about how there are more prescriptions for opiate painkillers in Louisiana every year than there are people in Louisiana. That's absurd. I can tell you that's gotten better. In 2012, there was 118 prescriptions for every 100 people. That's gone down a little bit, but it's still too much. The medical community recognizes this, and we've been moving probably a little bit too slow and too late, but we've been moving to cut back on opiate painkiller prescriptions. Painkillers, opiates should always be the last resort. There should be many things tried before a patient is placed on an opiate painkiller. And the medical community is recognizing that, and I think you're going to see that fan out through the clinics across here.
And is that they're doing this on their own? Are there laws in place? I mean, is there a mandate that they do this?
There are best practice guidelines that are being put out by any number of agencies, the CDC, SAMHSA, medical associations are all putting out guidelines now encouraging doctors to restrict opiates, use them as a last resort. The bottom line is that opiates are most of the time not a great medicine for chronic pain because your body builds tolerance to them. You take the same pill every day for a couple months, well, all of a sudden now you're going to have to double that dose to get the same effect. And that process doesn't slow. It keeps on going. So we're coming around to the recognition of this and trying to use alternative methods for pain control, and that can include other medicines, physical therapy, even chiropractic and acupuncture. All these things have a role, and they need to be thought of, all together. It's not just cut a prescription and move on to the next issue.
Well, we have a question. Thank you so much. If you would step up to the mic and give us your name and your question.
Jennifer Marusak. Actually represent the Louisiana State Medical Society, so I'd like the doctor to speak to a couple of things. We passed some legislation in 2014, since then mandating further use of the prescription monitoring program. Since then, I think we've had a lot more success. I know we've had a lot greater use by physicians and pharmacists. In fact, we've greatly increased the use. It's helped. In fact, we had a study came out just a month ago that said now we have had, we're one of 2 states that have actually had a reduction in opioid overdoses come into hospitals in the country. Only one of 2 states. So I think some of that legislation has greatly helped. But my question for you, doctor, is there are 2 things that I think have not been addressed that physicians have absolutely no control over, neither does law enforcement, or any other policymaker, and that's the payors. It's a lot easier and cheaper for them to pay for pills than to send a physical therapist to your home to give you the care the patient may need. And also, it's the way that the federal government is going to reimburse a hospital through Medicare, and that's their satisfaction sheets that they get. I don't know if everybody knows, but the hospitals give all the patients a satisfaction sheet. And if the patient says that they went home unsatisfied, i.e. in great pain, then the hospital's reimbursement through Medicare the next year is cut. So then the hospital is kind of incentivized to make sure that patient is happy as can be when they leave. So it all kind of comes down, as a lot of things do, to the mighty dollar, either through the federal government's reimbursement or the insurance company's willingness to say, hey, just give them some pills and send them home, rather than do exactly what you said, which is the physical therapy, the chiropractic, whatever other alternatives there are.
So a lot of players benefiting from the prescription of the pills. Doctor?
Thanks, Jennifer. Those were really great points. I'm glad you raised them up. For the prescription monitoring program, let me plug that one more time. So this allows physicians to check on a patient before they prescribe opiates to make sure they're not getting them from multiple other sources. For any docs out there listening who have not yet enrolled in this, you need to. And if you have enrolled and haven't used it in a while, I can attest it's gotten a lot easier to use. The program's gotten much better over the past couple of years. I log on to it at least 3 or 4 times a week in my own practice, and it's really easy to use. It's a great tool. Jennifer, the other points you brought up are so important. We can't just cut down on the number of prescriptions that we write in the medical community. We have to build access to other realistic treatments. We have to recognize patients oftentimes have legitimate chronic pain, and we can't ignore that. We just have to build realistic avenues for them to get treated that might not be opiates, physical therapy, others things, and insurers need to fund those equal to what they fund any other disease that patients have.
And so that is something that's a push that's going to have to come from the state level and the federal level in order to make that happen.
I think so. We need to push treatment for chronic pain. Non-opiate treatment for chronic pain should be funded like any other disease is funded.
Okay. Yes, we have another question. Your name, please, and your question. I recognize this face.
Yes, Lonnie Grenier. I'm with Odyssey House, Louisiana. We're the largest addiction treatment provider in the state. I just want to cite the statistic that was just cited. I don't think it's necessarily correct to interpret that result as a drop in hospitalizations due to opioid exposure, just because the services are being offered on less of a scale due to budget cuts. So I don't necessarily think that's a correct way to interpret that statistic. My question, first of all, to you is, since the prenatal exposure rate to substances has tripled over the last 7 years, how do you think that we as a state can combat that and come back from that in the face of budget cuts? And secondly, legislation passed, I think, from Representative Moreno 2 sessions ago that would make naloxone widely available through Louisiana. So Walgreens has been offering it for a couple of months, but the fact is that our emergency responders and NOPD officers don't carry this. And so if there's language in the bill to offer that, I would like to know why naloxone and Narcan aren't more widely available in case emergency responder or just a family member, social worker, anybody stumbles across someone who's overdosed on any kind of opioid.
Well, and I can tell you that's a lot of questions, and we're going to get to them, but LDH just issued the release that the standing order is in effect. We'll talk a little bit more about that, but Carice, I'll let you go ahead and address his questions, his many questions.
There's many questions,
Yes.
and I mean, every one of those questions has several layers of answers. You know, it's so complex in a way. And one thing that I would like to just add to the conversation is that in terms of prevention from the perspective of neonatal abstinence syndrome, we really also have to think about quality reproductive health care and making sure that that's available and accessible to women, so that for unintended pregnancy, 50% of all births in Louisiana are unintended. And so, you know, here we are, you know, growing our risk pool of neonatal abstinence syndrome by having women who are addicted not getting treatment. And so that's a big problem.
Yep, but one of the things in the information that you gave me is that when it comes to treatment, it's not just taking moms off of the drug. That is if I read it correctly, that's the worst thing that you could do for the mom, is to just take her off of it,
Yeah,
which sounds very, it sounds like that would be the thing to do, but in fact, it's not.
Yeah, it is counterintuitive, and, again, this is not my area of expertise, i.e. the opioid crisis and that kind of thing, and I'm not a clinician. And what surprised me was to hear that the preferred and best practice is actually to do a kind of a step-down approach and a replacement therapy, the medication-assisted treatment, MAT is what it's referred to, where you are replacing the opioid with methadone or Suboxone and, helping a woman, regulate how much she has in her system, thereby causing less issue and damage to the fetus and having less problems in that regard.
And we want to get to his question about naloxone. I think that's very important, but I want to make sure that we answered your basic question when it came to babies that are born with this addiction. So if we did not, then please come back and let us know. But naloxone, that's very important, one that you raised, and that made some news this week on Monday, as a matter of fact.
Absolutely. So thank you for bringing that up. Let's backtrack just a little bit. So what is naloxone? Naloxone, or the brand name, it's called Narcan in the brand name form, is a reversal agent that will serve as an antidote if someone has an opiate overdose. It will revive them. It has no other effect. It's one of the safest drugs I've ever used as a physician. It will take someone back to life if they have an opiate overdose, and beyond that, it does nothing else. It has no abuse potential. It doesn't get anyone high. Its only effect is to potentially save a life in the event of an opiate overdose. There's a couple ways it can be administered, either as an injection, almost like an EpiPen, or as a nasal spray as well. So it's really, really easy. The messaging that we like to put out is that anyone that has an opiate user or addict in their life, friends, family member, tenant, roommate, needs to have Narcan or naloxone on hand and know how to use it, because they might be in the point at some place in the future where they have the ability to save a life. So a couple days ago, Louisiana Department of Health issued a standing order statewide so that anyone can walk into a participating pharmacy and purchase naloxone without having to get a prescription. They can walk right in there and get that. That's a tremendous, tremendous thing, greatly expands access. We did something similar in New Orleans about a year ago, and we've had great results since then. So one more time, if you know someone in your life who is affected by opiate addiction, I encourage you to go purchase naloxone from a participating pharmacy, learn how to use it. Decent chance you will save someone's life with it.
And we can't stress enough, it's not treatment. It's not treatment. It is to literally save a life at that moment.
Yeah, the way I see it, it saves someone's life to be able them to come to the hospital in the hopes that we can then connect them to treatment.
And you were also saying, though, that there is a possibility, depending on how much the patient ingested, that the naloxone could wear off before before you're able to help the patient. So that's something important to, and that's why it's important to know how to use it.
Great, that's a great education piece. People that have naloxone administered on them always need to go to the ER, 911, every single time, because sometimes the naloxone will actually wear off before the drug does, before the opiate does, needing a second or third dose. So all these people need to go to the ER and get monitored.
Okay, that's very important. If you love someone and you know someone who's addicted, get the naloxone and be aware that you still need to get them to the hospital. You still need to call 911.
And real quick, just to interject, and again, I don't mean to keep belaboring how bad the epidemic is. We actually, our agents now are carrying this with them. I mean, I have a group of agents, and every one of them have been trained with this. And I mean, so I've never seen anything like this where we're actually providing a medical service as a federal agent. So just again, to belabor the importance of having this, and especially if you know someone that, is a possible addict, you need to have some of this available. It does work.
Judge Cheryll Keller with the Louisiana Workforce Commission. Glad to see you here, and I know you have some questions.
Good morning. I'm Cheryll Keller. I'm the Director of the Office of Workers' Compensation Administration, but I'm not here to talk about workers' compensation this morning because I think that opioid abuse, although it affects injured workers, is really a general health care problem.
Mm-hmm.
But what I'd like to do first is applaud our governor for approving the formation of the Opioid Commission to study the best practices and evidence-based strategies for prevention, treatment, and enforcement with regard to opioids. I think that he recognized a great problem in our state and is addressing it through that commission. Yes, ma'am. Okay. And so I have a very short story that I'd like to tell you guys. I am personally aware of a young man who was injured in a motor vehicle accident, went to see his physician, and walked out with a prescription for 90 hydrocodone. So my question is, one, is this a best practice and evidence-based strategy for treatment of pain? Two, should not the drug physician monitoring program be mandatory for all physicians because it will allow them to see who is receiving opioids to determine whether they're doctor shopping to get more opioids? And three, should there not be some education for our physicians in terms of alternative treatments for pain if you say that the 90 prescriptions for the hydrocodone was not a best practice and an evidence-based strategy for the treatment?
Good questions. Don't go anywhere because we want to make sure that we answer those questions. Dr. Cantor?
Yeah, Ms. Clark, I couldn't agree more. Thank you for saying that. It's not just about cutting back or educating physicians on what's out there, although that is really important. It's also about making sure people can access those, about funding those other options that are out there. Let me say something to people who may be in that position, who may be handed a bottle of pain medicine after they come in with a broken arm or something similar. No one wants to be in pain, but when you're taking prescription painkillers, your personal goal should be every day to try and take less than you did the day before, to try and wean yourself off of it as quickly as you can without putting yourself in too much pain. People are, I want to empower people to be in charge of their own health, and that's an important message that I don't think gets communicated to patients as much as it needs to.
Okay. I know that in one state, this is my final question, the doctors are required to make an agreement between themselves and the patient, which goes along with urine drug testing to find out if they're overusing their medication. Is there something like that on the horizon in Louisiana?
That's typically done when it's called a pain contract, and that's typically done when a physician puts someone on chronic opiates that says, you have this condition, I think it's going to be a chronic, long-time condition, and I'm going to treat it with opiates. They typically enter into a pain contract with that patient. But that's only half the issue because a lot of patients get prescribed opiates for an acute and a short-term issue like a broken bone or something, and that can also lead to addiction.
She mentioned something about doctors taking part in it's the PMP, did I say that correctly?
Prescription monitoring program.
It's not mandatory that doctors do that.
I don't believe it's...
Is there someone who wants to make a correction? Yes, come on up. And Jennifer?
That's one of the laws we passed with Senator Heitmeyer in 2014. If it's a first-time patient of yours for the opioid for a Schedule II or above, you do have to check the PMP.
You do have to check the PMP.
It's certainly
Thank you
a
for that.
best practice, and every physician should be checking the prescription monitoring program when they prescribe opiates.
And so does that directly impact the doctor shopping that she mentioned? Because that's a big problem, going from doctor to doctor, trying to get the fix.
I think so, because it's the way the doctor knows that's actually happening. And it's not about catching a patient in the act and say, ha, I got you, you were doctor shopping. It's about being able to say, I think you have an addiction, and let me care for you. Let me tell you some resources. Let me connect you. Let me treat your addiction. Yeah. I know the DEA has been really interested in cutting back on the ways people can get prescriptions from pain clinics and so forth.
That's correct. And in the other states, outside, the other states other than Louisiana that have had a PMP in effect for several years, it has been very, very effective. Specifically in Georgia and Tennessee, where I worked several years ago, we were very effective in working with the medical community and implementing the PMP, and it has really helped as far as the prescribing of opioids.
Well, we are running out of time. We'll be here very soon. We have probably maybe about 10 more minutes. So please, if you have questions, don't hesitate. Come up and ask. And yes, give us your name and tell us your question.
Yes, hi, I'm Allison Smith, and I work at LSU, but I work with pretty much all of the institutions of higher education across the state with substance use for college students in that age population. My question is, one, for the naloxone, are people, when you go to purchase it, although you don't need a prescription, do you have to scan your license to purchase it when you purchase it, like pseudoephedrine?
That is a good question. Is Tracy here? Tracy is here. Tracy is with the Office of Behavioral Health. I'm going to ask you to make your way over here to the microphone so that we can all hear what you have to say. Tracy's very knowledgeable in this area. She is the State Opioid Authority. That's a big title, very important, and she can address this question. Okay, go ahead, Tracy. Ask part one of her. Answer part
No,
one.
you don't have to scan your license. And, that was eliminated because the legislature did not want people to feel that they would be known as drug seeking or, have an addiction.
So you don't have to scan your license to get naloxone?
You do not.
You do not, okay. And can I ask you the cost? Is it expensive?
I'm not sure of the cost, to be honest. Narcan is normally not expensive at all, but the dose kits can be around $65. Dr. Kenner, are you aware of the specific price?
I can tell you Medicaid covers it.
Yes, it is.
Medicaid covers it.
Yes, it's covered by all 5 of the Bayou Health plans.
Okay, all right, great. And your second question?
The second part, because I work with college students across the state, what would be your recommendation for college pharmacies or health centers? Should they be advised to start carrying it at the health centers on their campuses?
I think that'd be great. Yeah. When, I think, someone could have a roommate that uses, I think that would be tremendous. And I think college health centers have a great role in connecting people to substance abuse resources. Yeah.
Great, thank you so much. Tracy, do you want to add anything more about the legislation concerning naloxone?
No, just that the standing order was signed by Dr. Rebecca Gee last Monday, and that's going to greatly enhance access, as the panelists have indicated. So we're very excited about that because our goal is to get it in the hands of as many people as possible. Because like they indicated, you don't know if someone has an addiction.
Mm-hmm. And there are other pieces of legislation I know you've been working on. Oh, she's telling you to come back. I know there are other pieces of legislation that you all have been working on. We'll get to those in just a moment, but I want to get your question, yes, before we run out of time. And your name.
My name is Joanne Brown. I'm chairman of the Louisiana Association of Opioid Providers. I want to, first of all, thank y'all for doing this. This is just amazing that you're doing this. I've been doing this for 20 years, treating heroin addicts with the best practice. I was awarded an international award for my services in the opioid treatment world. I have one of my employees that serves on a national committee that works with SAMHSA. And I hear everything you're saying, and it's correct. And Tracy is our backbone. She just keeps us going, and she's wonderful. She does a great job. But the thing I have is the stigma in Louisiana. There's got to do something about the stigma. I give methadone. We also do Suboxone. We're on the patient monitoring pharmacy board. We're licensed by drug enforcement, by the pharmacy board, by the state, by the federal government. You name it, we're licensed by them. But the thing that I'm seeing more and more now is the chronic heroin addicts coming into my facility. I'm seeing more and more and getting more reports of young people dying from a bacterial infection, not from overdoses. And I think a lot of those overdoses that are saying they're overdoses are actually from bacteria infection. I worked with Our Lady of the Lake on a patient that was there the patient was on Suboxone, and she couldn't take pain medicine because on Suboxone you can't take pain medicine. So they had to take her off, and they had to do major surgery with no pain medicine for her. When she got stable, I talked to the people at the hospital about their policy on people coming into the emergency room and into the hospital on methadone and Suboxone. While this patient was there, they did change that policy. What impressed me most was a young doctor out of Tennessee that graduated from the University of Tennessee. In Tennessee now, it's my understanding that they mandate for all physicians to have a 3-hour course in opioid dependency and treatment, and especially in opioid addiction. Now, I will point out that we treat chronic heroin addicts. Most of ours are chronic, but we have a horrible stigma problem. We refer to the state providers, and because we need their help. And what happens is they'll advise them to get off of methadone.
I'm gonna give them time to answer your question. So before we leave here, the stigma, that's a major
stigma,
problem.
yeah.
The stigma of it. What can you all say about that, and how can we get over the stigma? Because as you said, I mean, this is, we need to help these people. We don't need to ostracize them. We need to help them.
Okay, so since I'm the communications person, I mean, that's what I do. So, I mean, changing social norms, changing stigma, those are all really important things, and I think there is a role for education and using strategies to really reach out to families and to individuals about this issue and what to do about it, you know, that is not connected to perpetuating stereotypes and racism and stigma and things like that. It takes funding, like everything does, and but I think there's a role. I mean, our document that the Perinatal Commission put together is also being used by the Commission on Opioid Use, it's, you know, for that area, and it is chock full of recommendations. And I mean, I really think what would be awesome is if we could just systematically go through those recommendations and see where are we with these things?
Yeah.
What can be done? What's the next step? Everyone's going to have to play in this sandbox. It's not something that any one agency can take on. So I don't know what I'm saying. I don't know if I'm answering your question, but stigma is one of those issues that we do have to look at very seriously.
Yes.
If I could add to that, you had brought up the example of diabetes before. You would never make someone feel guilty because they had diabetes.
right.
And addiction is a disease just like that. It's a disease that can be treated like many, many other diseases. I've cared for many opiate addicts clinically. I have never met one that did not want to stop using. Never. Everyone wants to stop using, and it's very, very difficult. And feeling guilty about letting your family down, letting your loved ones down, only makes it harder for someone to get treatment. So it starts about being compassionate, letting people know that you care for them, that this is a disease, you're going to help them through it, and knowing that there are some good treatments out there that can let you do that.
And really and truly, it starts with everybody in this room. It's not just somebody else out there somewhere. It's every single person sitting here in this room today. What you're learning, we really, really hope that you will take it to heart and that you will share it. You will share it with your organizations. You'll share it with your friends. You'll share it with your coworkers. And we will learn and we will share what we learn. And so the whole point of this is getting correct, helpful information to help everyone we can help. That's what it's going to take.
I'd just like to say one more thing. It kind of annoys me sometimes because I hear it's the doctor shopping problem. You know, there's a lot of really good doctors out there that feel like this gentleman does.
Yes.
But there's just a few doctors out there that violates everything. So I think we just need to say that I've met many of the doctors that are just as concerned about all of this as I am.
That's an important point. Thank you so much, and thank you for the work that you do. We appreciate it. Yes, step on up to the mic and give us your name and your question.
Hi, my name is Chelsea Rainwater. I operate a grassroots community organization in the Baton Rouge area called No Overdose Baton Rouge. We provide naloxone free of charge to anyone in the community who wants it. And our harm reduction philosophy is basically to empower people to make decisions about their own health, and that includes opioid users. And one thing that we've seen that's significantly prevalent is people who are using, if someone is overdosing, they are terrified to call 911 because they're afraid of getting arrested. So this stigma infiltrates all aspects of their life, and that includes, I've had people tell me that they've gone to the pharmacy with a prescription for naloxone, and they've been shunned by the pharmacist and treated with discrimination. And so I guess you kind of answered the question about stigma that was just asked, but I just think it's worthwhile for us to think about that. I mean, this affects many more areas of these people's lives than you know.
Well, and I'm glad that you raised that point, and I'm going to ask Tracy to come back up to the mic, because I mentioned earlier we have lots of legislation, not just concerning naloxone, but she mentioned something that I think applies to the Good Samaritan law, which a lot of people may not know about, and I think it speaks to that very issue that she just raised.
Yeah, thank you. In 2014...
And get a little bit closer so we can hear every single word.
In 2014, we worked with legislatures to amend the Good Samaritan law, and basically it says that if you call 911 and drug paraphernalia is found at the site or any type of drugs, then you won't be arrested, because that is absolutely correct. People do not want to call 911 because they don't want to be arrested.
Right, and I hope that you will take that information and share it with your organization. You will not be arrested if you call 911 and you need help.
Correct.
That is the Good Samaritan law. It is in effect, and it's in place right now. You will not. So that's a bit of information you all can take right out of the gate here with you and spread the word so that people know it with the different organizations that you all are working with, the Good Samaritan law. Thank you so much, Tracy. Yes, sir, if you would please step up to the mic and give us your name and your question.
I have a couple of statements I'd like to make in anticipation of this. My name is Don Hidalgo. I've been in the trenches treating substance abuse patients for 41 years. So I think that gives me a little credentials to be present here today.
Thank you for the work that you're doing.
Pardon?
Thank you for the work that you're doing.
Okay. I find that stories probably tell better what the problem is than statistics, although statistics are important. We operate an employee assistance company, and a number of years ago we got a phone call from a young woman over in Atlanta stating that she needed to come in and see one of our counselors. What had happened was her company, she was a member of the senior management team of this company. She was 32 years old, an MBA background, making about $250,000 a year, and got drunk 3 or 4 times in front of her peers at senior management programs. So her boss says if she's doing that in front of us, then obviously she's got an alcohol problem. Let's send her to the employee assistance program. She gets to our office and she says to our counselor, I've been trying to work up enough courage for the last 2 years to come here to talk to you about my problem. My problem is not alcohol, but I knew if I told my boss that, he would send me to the employee assistance program. My problem is, and she rolls up her sleeve, and she's got track marks all over her. And she says, I'm shooting heroin, obviously. Now, my question to you, going back to the attitudes that you raised earlier, and that's the key to what's going on here. She said, I thought that my boss would have said, if you're an alcoholic, we'll treat you. If you're a heroin addict, we're going to fire your ass. Now, the prototype, and you mentioned about what do they look like, I guarantee you that the average heroin addict in the public's opinion is not a 32-year-old MBA background, senior management, female, making $250,000 a year. I cite this as an example of, unless we change the attitudes towards alcohol and drug addiction in general, we're just kind of blowing it in the wind. So I'll raise this question for you from the governor's office. Are we going to do something about this, or is this another feel-good effort? And I don't mean to be critical of you, but like I said, for 40 years I've been here, and I've seen a lot of feel-good programs that do, good press, and it dies. And unless we do something about it, it's going to die. And I can promise you, you've got some of the strongest opposition in the world working against you in this. Number one, the insurance companies, as has already been said, are looking for the easiest, quickest way out, and they'll prescribe medications and approve it. They do not want to approve alternative types of treatment. Secondly, the average physician makes a lot of money on dispensing medications. Today, if you go to see a doctor, I guarantee you when you walk out of there, if he didn't give you a prescription, you don't feel like you got what you went in there for. There is a magic bullet concept on the part of the public and on a lot of our providers that believes there is a magic bullet for everything that exists. And until we change those attitudes, nothing's going to happen. Thank you.
Thank you. Thank you so very much for your statement and so very much for the work that you are doing. You're absolutely right. I think you're echoing a lot of what we've heard here today. And I can assure you that what the governor is interested in is not just making people feel good, but doing good. He's already established the Opioid Commission, and it's not going to take just the governor. It's going to take legislators, and it's going to take everybody in this room working together to make this happen. And we have a governor who is very interested in making good things happen for people. He recognizes that this is an epidemic and that something must be done about it. And he is working his very best to do something about it. And he's going to hear this, and he will continue to do what he can to make sure that people get the help, the kind of help that they really, really need. And so we appreciate your comments and really the work that you and everybody here is doing on behalf of those who really do need the help. Yes, ma'am, your question and your name. Yes.
My name is Jessica Anderson. I'm a licensed addiction counselor at Fairview Treatment Center, and I do want to commend you for the work you've done. I look up to you both. So, thank you. I also want to preface this with saying that we are overwhelmingly excited with Medicaid expansion. The majority of our clients do have Medicaid. If they don't have Medicaid, they're still covered under the SAP grant, indigent population. What we're running into, however, is anyone who treats addiction knows it's not one and done. Sometimes not 2 and done or 10 and done. We're getting clients who are IV drug users, opiate IV drug users, coming in for detox, and Medicaid wants to deny them because they say they've had enough treatment, they should be good, and they don't want to provide services. So in the instance, we're stuck with, we can't afford to keep them financially, which as a clinician or anyone who has a heart doesn't ever want to have to put up with. And addiction is not a cold, it's not the flu. You don't just treat it and say, go on your way, etc. So is Louisiana proposing anything to help out? What can we do in those instances?
Who wants to take that one?
Let me just say, I applaud what you do, just like I saw Odyssey House here earlier and other treatment centers across the state. This is where this battle will be won, is in providing treatment. What you brought up was, I mean, that's an absurd scenario, right? Can you imagine saying, well, we tried to treat your blood pressure, but this first round didn't work, so that's it, we're done. We would never do that for any other disease. Why would we do that for someone's addiction? So I think the path forward is for people like you to continue bringing this point up, that we need to fund addiction treatment at the same level that we fund any other disease.
And Tracy, you got up because you have something to share on that note.
Yes, we have requested Medicaid coverage of methadone treatment, and currently it's before the legislature. So they said that it's a funding issue at this point, but we are trying to expand a treatment. We've also received the Strategic Prevention Framework grant, and it's $370,000 per year for up to 5 years. And that's to educate the public, like everyone has said, you know, related to stigma and persons not want to be known as needing treatment. That's an issue. And the great thing about this grant is that we're also able to start in schools to educate children and, you know, just on the general issues related to drugs at an early age. We've also received the Medicated Assisted Treatment Prescription Drug and Opioid Addiction, MAT-PDOA, grant, and it is $1 million for 3 years. And that grant is to increase access to medicated assisted treatment, especially our priority population, like Harris mentioned, pregnant women and women with children.
Okay.
And we're also currently working on applying for the State Strategic Response Grant. And that will be $8 million per year for 3 years. And that grant will encompass prevention, treatment, and recovery. So that's something we're very excited about, and that goes in February. So yes, we are working very hard to secure additional funding and to expand access.
Awesome. Thank you so much. We are quickly running out of time. 2 more quick questions. Yes, and your name, please.
I'm Dr. Janice Peterson, the Deputy Assistant Secretary with the Office of Behavioral Health. And Tracy started that discussion about, you know, what are we doing to help, and just really, really pleased that the governor has allowed us to start writing for grants. We have secured several grants through SAMHSA. There's money coming in through CDC, through the Office of Public Health for some data surveillance. There's a lot of things going on, and Tracy mentioned the $8 million grant that we're currently working on to also expand services to help with our prisoners coming out of the DOC system. So we have a lot going on. You'll be hearing a lot about those grants and trying to get your partnerships together with our local governing entities and our 10 statewide opioid treatment programs. So we're just really excited and got some help finally. We asked for help. SAMHSA, the federal government, has stepped up to the plate, and we hope to get this money and do some really good things for the citizens of Louisiana.
Thank you. Thank you so much for sharing that. I appreciate it. Our last question, your name and your question.
More than a question, it's just a comment. My name is Marilyn Mangum, and I'm the Executive Director of LACACT, which is the Addiction Professionals and Providers Statewide Association. And our people really do good work. We just take what is presented and treat them that they come in. But many of the clients that do get to us started with prescription medication, and then the doctors discontinue because it wasn't to be used for indefinite use. but the patients have already become addicted, and so they start self-medicating on the street. They don't see their dealers that the legislation was aimed at. They see the runners who have much less on them. And so that piece isn't really working. And then the runners don't have the prescription medication, and so they say, but I have this great alternative that's really $5 and it's cheap. And so now you have a full-blown heroin addict. And it just seems appropriate that when the doctors discontinue the opioid use, that before that's discontinued or while it's being discontinued, that they send them for a brief intervention and referral for treatment where appropriate, because that's where we might can catch some of these dirty needles, endocarditis, the really mess that we get that's following the really clean drugs that are prescriptions. So thank you.
Thank you. Thank you very much. Thank you all so much. I mean, this was a really great conversation, and I know that we couldn't get to everything because there's so much more, but I really encourage you all to connect with each other, to network with each other. There are a lot of people here who have a lot of great resources, so please don't leave here without meeting someone and getting some resource. Thank you so much to our guests, Brett Byerly, Curry Schulman, Dr. Cantor. Thank you all so very much. We'll see you next month. Thank you.